just go over our agenda briefly. So we'll speak about CST in general, so background, purpose, and guiding principles. And then the bulk of our session today will be working on the endocrine workflow and demonstration, as well as having a discussion about the Diabetes Center power form design. And then we'll go through the inpatient nurse educator workflow, as well as validating that content. A brief chat about downtime procedures. Sometimes technology does fail us and we need to know what to do in those circumstances. I'm aware that I haven't scheduled in a break here, so we will check in maybe about the halfway point and see how folks are feeling. So we'll just do some quick introductions. I'm just going to bring up our participant list here. I think for the interest of time, we'll introduce our SMEs and our subject matter experts. And then as our folks from CST are speaking or presenting, they will introduce themselves. So I already introduced myself. Brandon, do you mind introducing yourself to everyone on the line here?
Sure, yeah, hi, my name is Brandon Glom. I'm one of the endocrinologists at Vancouver General Hospital.
Thank you, thanks for joining us today. Keisha.
Yeah, sure. So I'm Keisha Provo. I'm the PCC for the Diabetes Clinic here at VGH.
Thank you. Thanks for joining us today. And I'm sorry, the first initial M and I'm assuming last name Werner.
Hi, I'm Maureen Brenner, dietitian in the Diabetes Center at St. Paul's.
Thanks for joining us today. And first initial M, last name Brad. Sorry, as I'm mispronouncing your name.
Hi, my name is Moira. I'm one of the dietitians at Richmond Hospital.
Thanks for joining us today, Moira. Melody.
Hi, my name's Melody. I'm the CNL for the diabetes program at St. Paul's Hospital.
Great, thanks for joining. And Ruby.
Hi, my name is Ruby. I'm the new CST educator here at VGH Ambulatory Care.
Thanks, Ruby. Nice to have you with us today. Sarah is a part of our team, if I'm not mistaken. And then SSY.
Hi, I'm Sarah Sy. I'm one of the geriatricians working at VGH, but I also work at St. Paul's.
Great, thanks for being here. Suman.
Hi, my name is Sue. More can you Oh, sorry. I'm from Richmond Hospital. Thanks.
Oh, thanks, Suman. Sorry, I think we're just getting a little bit of feedback there. Is there anyone else on the line that is a subject matter expert joining us today that hasn't introduced themselves? Perfect. Okay, thanks everyone for joining. As you see, we have folks from a couple different sites today. That's really awesome. We'll get some input from everyone. All right, we'll just jump into a little bit of background about CST. I think for some people, this might be a little bit of review, but for those joining us for the first time, it's nice to have some context as to what we're speaking about. So CST is the Clinical and Systems Transformation Project, which will transform healthcare and processes to improve safety, quality, and consistency of patient care. Health facilities across Vancouver Coastal, PHSA, and Providence are planning to roll these changes out within the next few years. So you can see that we have 3 different health authorities coming together. Our project drivers here, so patient safety is first, reducing errors and adverse events, best way every day, so improve quality and consistency of care, FaceTime, not chase time. So improving the healthcare experience for patients and care teams. And lastly, drawing on data. So gathering better data to improve health system planning, research, and proactive care. Our CST design principles. So our focus is enterprise design, and you'll hear that term a lot. And what that refers to is the 3 health authorities that we're working with. So we're configuring for enterprise-wide, meaning coastal, Providence, as well as PHSA. So decisions that we make need to think about all the stakeholders involved. So our must-haves when we are designing. So when would we make a change in the model system? So we need to think about safety, regulatory, financial, and content changes when we are designing. The purpose of this session today, so we're going to continue to learn about the clinic's current state, that's the VGH Diabetes Center, as well as validate what content works and identify any gaps or changes that are required for the future state. So the role of a subject matter expert, you'll hear that referred to fairly often as a SME. So a SME is someone who contributes as an expert and a representative for your area to discuss workflows, recommendations for future state workflow. And when we say future state, we're referring to using the CST starter system. It's also someone who understands and thinks strategically about processes and workflows within the clinical setting, as well as being familiar with their health organization policies and documentation. They're also able to identify and confidently make informed decisions within their areas of practice. And lastly, consider the requirements and needs of stakeholder groups across all the organizations that I've spoken about. Any questions before we dive into the content of today? All right, I'll take silence as a way to move forward. So we have a few more specific questions for our endocrinology team. So I'll dive into those. Not many, but Dr. Gom, if you would be able to provide any answers to these, we would be really grateful. So the first one is, are there any special imaging or diagnostic labs ordered within the VGH Diabetes Center?
Yeah, I would say certainly labs we do all the time. You know, it sort of depends on the endocrinologist who's looking after them. I would say do you want an actual list of which tests would be done routinely?
That would be really helpful if there are any sort of unusual or non-standard labs. I think that's more what we're looking to pull out today. But if it's sort of your fairly standard order set of labs, most certainly we'd like to have that information. But if anything sort of odd or unusual or not as standard pops out to you, that would be helpful.
Yeah, I mean, oh, sorry, I don't know what happened there. I mean, most of them, the vast majority are very routine, like hemoglobin A1C, for example. You know, if we're doing a CBC, creatinine, lipids, urine ACR, like those are very standards.
Mm-hmm.
We sometimes order tests that might be a bit not typical, would be like insulin, C-peptide, and an anti-GAD antibody, anti-glutamic acid decarboxylase antibody. So every so often we'll order something like that. And then in terms of, I mean, and you know, most of us are also endocrinologists. So every so often we might see someone, let's say, who has a thyroid problem as well. And so we might add a thyroid test or something onto that. But the most routine would be, the most important obviously would be the A1C. That's sort of always done.
Okay, perfect. And the reason we asked is just to ensure that these tests exist in the system, and if they don't, need to identify that as a gap.
Yeah, I'm sure the routine test we do would be already in the system. The like I say, the three, I mean, I'm sure insulin and C-peptide are in there as well. The anti-GAD antibody would be something just maybe to check into, just to be sure.
Thank you.
That's a send-out test.
Okay. And do providers within the clinic refer to surgeons in particular?
And then, sorry, just about the imaging part, just to go back to that. So we don't do very much routine imaging. Sometimes some of us might order like a Doppler ultrasound of the legs to do an ankle brachial index. Every so often we might do something like that.
Okay. And is that done, that's not done in clinic, correct? That's done.
It's not done in the clinic. No, that's done. You can do it at VGH or other hospitals typically, or other radiology suites.
Okay.
And do providers refer to surgeons? We refer to ophthalmologists very commonly.
Okay. And is that the eye care center at VGH, or do you usually refer out to private clinics?
I think it depends on the individual. Many of us will send a lot of people to the eye care center. But sometimes, let's say, for example, if someone came in and they were already seeing an ophthalmologist that was in Richmond or Surrey, for example, then we want to send them back to the same person. So then we refer them to the same person they've seen before.
Okay, thank you.
We might also sometimes refer to vascular surgery would come up potentially. And typically that would be at VGH. And then we might refer to podiatry potentially as well, which would be sort of, again, that would not be at VGH, that would be at Mount St. Joseph's or an outpatient sort of a private clinic.
Okay, thank you. And then it's our understanding that right now the insulin samples that are within the clinic are sort of ordered and maintained by the endocrinologist. Is that correct?
I mean, I'm sure Keisha can speak a little bit to this as well. We have contact with the various drug reps, and then, and you know, so when samples are needed, they're sort of, we speak with the drug reps. I'm not sure exactly how Keisha does that, but us as endocrinologists, we often do sign that, and so we have samples of the various insulins available in the fridge.
Okay.
Carmen, are you okay if I just speak to that? So it's Keisha speaking. So just in regards to our practice, the samples, the endos have to give out the samples. We do have obviously samples from the drug company in our fridge, but it's not for the nurses or the clinicians to give out. It's actually for the endos that have to give that out, not us. So once they give it to the patient, then obviously, you know, we can use that sample that they've given us or to the patient to go through the teaching of that. Otherwise, for us, when we do our teaching, we would use saline.
Okay, so the sample itself needs to be
given by the endocrinologist.
I see. So this insulin would not be used sort of as a ward stock medication if needed to administer. Is that
it's correct? Not on, it won't be Carmen, it's not going to be on the formulary if that's what you're talking about. It's not ward stock. It's just samples that are given by the drug company for the endos to use for their patients. Okay, perfect. Yeah, we're just trying to get a better sense of what those samples were used for.
And then lastly, so if either Keisha or Dr. Gom could expand on the current use of the STAR program in the Diabetes Center, our understanding is that it is used by primarily one provider at this time, but we just want to get a sense of if this is a system that is used more widely than our understanding, and if there's a want or need to continue to use it.
I don't even know what the STAR program is actually, so I think that speaks to it.
I can speak to it first, Carmen, and then maybe Sarah can pipe in a bit if she wants to as well, because Sarah also has used it in the past. So basically the STAR program is a form of e-charting that was brought in for Dr. Maneely's patients. I think he outsourced it, so it's actually not part of the hospital documentation, like usually the endos are supposed to chart in the PCIS. So right now, from my understanding, is that we only use the STAR program for Dr. Maneely's patients. And once Dr. Maneely has retired, we will no longer be using that program. Everything else would be obviously in the Cerner system, or right now, currently for the other endo clinics, we do paper charting. So Sarah, I don't know if you want to speak a little bit more to that too.
Yeah, Grady Manili, who uses the program, had been using it more like also as his research database, because in our geriatric diabetes clinic, we record other metrics as well, like what their mini mental status exam results are, or their mini cog, or like the cognitive testing. And then we also would record like what their basic and instrumental activities of daily living are, and more of like a social history and their frailty. So I think Dr. Manili had been using that as like more like a database for his research, but as he transitions towards retirement, that he will stop that. But it could be something, I'm not sure in the new CST whether we could incorporate some of the sections for that for the geriatric diabetes clinic.
Okay. Is this an imminent retirement? I think that's a hard question to ask, but I'm sort of just trying to get a sense of the timeline as to how long this program is desired to be used by this provider.
Okay, well, I can try and answer that. I'd spoken to Dr. Neely last year, and he had mentioned to me it might be 2 or 3 years away for his retirement, but things change, and that's all I can kind of answer right now. I don't have a set date or year when he's going to be retiring right now.
Yes, that's fair. Just trying to get a sense of sort of the duration of this program. Any other questions from the CST folks regarding this?
Yeah, this is Stephanie. I just have a question about the geriatric diabetes patients. In terms of the questionnaires that you provide them, or some of the measures that you work with them, I'm just curious about, let's say, the MMSE or the Lawton. Is that something that you would document into the chart? And out of curiosity, would you need those measures documented in the future?
Yeah, so usually I document it in their chart. Like, well, right now I just dictate it in their transcription note because it's important to know what their cognition is like and how it's changing over time. So if we could incorporate that into the CST, that would be great.
Okay, awesome. Thank you.
Any other questions from the CST side? Perfect. And how about our SMEs before we move on? Any questions or comments around provider questions? So the next part that we're going to speak about is reference.
Excuse me, it's Moira. We didn't actually hear what Carmen said. Could you repeat it?
Sure. Are you able to hear me okay?
I hear you okay now.
Okay, perfect. I was just asking if there were any further questions around the provider questions or any comments that needed to be added.
Hi, it's Moira again. I'm not sure if we should mention this. You were mentioning the STAR program for charting. We use EMR for charting. I don't know if that's important for you to know at the moment.
Thank you. Yes, that's very helpful. We'll take that down. That was EMR. Is that correct?
That's correct.
Okay. All right, so we'll move on to our next section here. So reference text in referral orders. So a little bit of background on this. So currently, St. Paul's Diabetes Center is the only location that is built in Cerner to refer to. So VGH and St. Paul's Diabetes Centers will have different, do have different referral criteria. Once both locations are built into this order, either site will be able to be chosen from this drop-down menu. So this location section here will have the VGH Diabetes Center as well. And so the question that we have is, how would site referral criteria best be provided to the referring provider in the system? So one option that we present would be something called reference text. So that would be text within here that sort of broke down, if you're referring to VGH, these are the referral criteria versus St. Paul's, these are the referral criteria. So I'd just like to open that up to any comments or suggestions from our SMEs.
I mean, that sounds fine from my perspective. I mean, to have it actually listed there would be very helpful. I mean, one thing I will note is that a lot of our referrals will come from outside of CST. You know, they won't even see that anyways, but for, let's say, if it's an inpatient being referred to us or someone else on CST, then I think it would be useful to have it. I mean, I suppose one option would be to actually have checkboxes that come up that list a criteria and you check each off. However, the one issue with that is that just creates extra work for the referring provider. So I'm not sure that that's the best option, to be honest. As a physician, I mean, there's so much paperwork and so many things to do already in terms of that. So my personal opinion would be better if it just had the criteria listed there on it, just as you mentioned.
Okay, thanks for both those suggestions. We'll take those back to the team and discuss that. Does anyone else have any suggestions with regards to the referral order?
No, like I agree with what Brandon just said. It's Keisha, so I agree with that. And I know you'll probably get to it later, but what happens if we get the referral from outside? Like, majority of my referrals are from GPs and they wouldn't be using the Cerner system.
Yeah, that's a great question. And I believe that is the next slide, or the slide after will show sort of a map of how internal and external referrals would come to you.
It's Melody speaking. Yeah, I agree with Dr. Galm that we should have the criteria there. We're starting to get, now that we're on Cerner, we do get a lot of referrals from ER through this system, through other departments. And so I think for them to know the criteria for each area. But a majority of ours would come from SPH anyhow, so I don't know. But if you're going to show up with the two different options, then you should have a criteria so they know.
Thank you.
Carmen, it's Keisha here again. I just want to, just another question. So and this will be separate too, but we also get referrals from the inpatient, for the inpatient RN, like from the ward. So it's actually for the diabetes educator. It's not actually going to be, it's not necessarily for the endo. So would that go in this area as well, or is that going to be separate?
That's another great question. And Stephanie, correct me if I'm wrong, but we will go through that process a little bit later today. Is that right?
Yeah, so actually it is two different orders in Cerner. And I'll go through the difference between this one and the consult order for the diagnosers.
Sorry, it's Brandon here. Just one other thing. If you wouldn't mind, if it's possible, the reason for referral, can you automatically populate that as diabetes? Because I mean, this is always going to be a referral for diabetes. And if needed, they can change it, but it just saves one extra click or one extra step for the referring provider.
So I believe that's, so it is a mandatory field, but I believe you can free text it. I don't know the, if we can build that in, but we can take that away and come back to you. I'm just going to pop into our chat here. Perfect. Thanks, Simon. Okay, so it sounds like we have a couple different takeaways from here, and then we will bring that back to our SMEs here at our next session. So a little bit more detail about how those external and internal referrals come to the clinic. So with the external referral, it sounds like a lot of those are coming from GPs. So that would be the referring provider. And that's going to be that paper referral. And that'll come in through fax in what's called our work queue monitor. The clinic MOA will receive that. and they will then create a referral encounter and set that to ready for triage. Once that is set, my understanding is that Keisha PCC is reviewing and triaging those referrals, and then that would go into either accepted or rejected. In terms of an internal referral, and that is meaning internal as someone who is using CST Cerner. So the referring provider would place a referral order to the diabetes clinic at the appropriate site based on that criteria. That would be received by the clinic MOA, and then the same process would ensue for the PCC to either accept or reject that referral. And the next steps of that accept and reject referral will be covered later today. Any questions on this high-level process? We are going to jump into the system demo fairly shortly. So this, I know it's a little abstract looking at pictures. It might sink in a little bit more when we're looking at the system. So I'm going to hand it over to Kalina to provide the day of clinic visit demo. So I will stop sharing here and give control over to Kalina.
Thanks, Carmen. Carmen, Victoria, would you be able to enable my screen sharing ability?
I think so. Give me a second.
Thank you. Okay, thanks. Give it a try. Okay, is everyone able to see my screen? Yeah. Yes, okay, perfect. Hi, everyone. So I'm going to do a high-level overview of CST Cerner, exploring the workflow tabs in PowerChart, provider documentation options, as well as going over how to place orders. So jumping right into PowerChart, we typically start with the ambulatory organizer, which is what you see here. Shows you the schedule for the day. And here you'll see the patient with the appointment time. And once you click into the patient's name, you will land on the provider view of PowerChart. And on top here, these are the different workflow tabs that's available for a clinic. Some of them may not be applicable, so you can always cross it out just to clean up the view. And to get it back, you can always go to the plus button here and just to add it back. So for the purpose of this demo, I'll just be briefly going over the outpatient chart, the different components that are available. Okay, so looking at the left-hand side here for the different components, you can also move these around however way you wish. And also, again, to clean up the view, you can always remove the ones that are not applicable or the ones that you do not wish to see. So for example, if you unclick links, it's going to refresh and it's going to disappear from the page, just to clean up the view again. The other thing I'd like to point out is once you start documenting in these components, for example, chief complaints, I've entered some data here just to show you how they will automatically be pulled into the note. So we have chief complaint documented, some histories, allergies, and home meds. So once they're documented into components, and if you click on the note type hyperlink or the shortcuts here at the bottom of the page, if we click on the endoclinic note, the data automatically gets pulled into the note. So you don't have to document from scratch or type from the beginning. And if in case a template doesn't work for a clinic, you can always go for the free text note, which is just a blank template. And you can use Fessor or macros just to do whatever you need. So these are just some of the auto texts that are available. Any questions so far before I move on to quick orders?
Sorry, this is Sarah Sai. I'm just wondering for the blood glucose, like patients bring in like their glucometer or if they have like their CGM, the continuous glucose monitoring. I'm just wondering, is there going to be a section to enter that?
Carmen, do you happen to know?
Yes, it's a good question. So they're bringing in sort of an ad hoc graph that they're bringing from home, or is it a printout from their sensors that you're referring to?
So some of them, it's like we have the printout on a different platform, like either Dexcom or Freestyle Libre, like Libre Review. But for other people, they just bring in their glucometer and they just show us the numbers. So I'm just wondering, like, where can we enter that? Because I don't really see a section. Is that just we enter in the physical exam, or?
So yeah, it can go into a couple different places. This is something that we've been chatting about as a team, sort of what to do with these measurements. And actually, if it would be okay if I asked St. Paul's SMEs on the line, sort of what you're doing with that data that's coming in from patients and how you're capturing that in the system.
So right now, I was just about to explain, we actually use it in an auto text in documentation. So that's the only place we're doing it. And what our doctors do is actually look at our note and then copy and paste it to their note.
Thanks, Melody. So that is, yeah, that's something to think about, but we can definitely take that and talk about that as a team and present some possible options at our next meeting.
Sorry, Brandon here. I had actually raised this last time as well, just about that, and it didn't seem like it was at least pulling it in from Dexcom or LibreView didn't seem like a very plausible option. I wonder if is it possible to put images or screenshots or something? I know they mentioned putting a PDF wasn't possible into CST, but can a screenshot be put in, for example, or like a picture, a photo?
Here at St. Paul's, what we do is actually print, we have to print it, and because of the faxing, like you basically are scanning it into the chart. So then you have like a documentation. That's how it works for us.
That just seems so like an extra step for you guys, just to print it and then scan it afterwards. I mean, if we, like many of us will view it electronically on our screen. And so if you could just take this is actually what I do with my own EMR right now, just take a screenshot of like the AGP, the curve or something, and then just put it into the notes. That would be super helpful. So I'm just wondering from the CST people, is it possible to put like a screenshot or a JPEG or something into a note?
The answer is not yet. Yeah, I mean, there's lots of applications that lay over top of Cerner, but that's money and time and future kind of processes. The only real images that we have in the system at all are related to cranial nerves. I think there's some for surgeons. Like it's very, very basic, but not like you're saying, like drag and drop an image into a note. That'd be great, but unfortunately not.
Okay, thanks.
And then it's Keisha here. I just want to ask, so like Dr. Sai was saying, like for the blood glucose, like readings, it's a pity that you don't have, I know we're going to discuss it some other point, but to have that tab for blood glucose readings, and then it can be put in there at least, instead of, do you know what I mean? Because that's easy for everyone to go to.
To see more of a trend of the patients at home monitoring.
Well, because it's diabetes, so you're obviously that's one area that we're going to be looking at is their sugars. So it would be ideal to have it in one of those tabs so that you actually have a tab that you can put it in.
Yes, no, certainly I hear the need for it. We'll take this back as a team and see what we can come up with, and at our next session we'll hopefully have some options to present.
So sorry, can I just bring this up again? Because this actually is a really important point, because this is what we look at like all day in clinic, like, and I think that's what Keisha's trying to say. So Melody, can I just ask you, when you said you had like an auto text that goes in, like, is it, I don't know, is it like how do you enter it? Is it a table and you have like, you know, AC breakfast, AC lunch, and then you sort of tab over and enter them all manually, or how does that kind of work?
Yeah, so it's like in our documentation, we all have these, it's auto text, right? Like when you fill up, and it's like basically our forms that you would just open up, and it's basically a Word document, and then we would just enter our information. So it's like a free text, but in a Word documentation. And then what our doctors have been doing, or, you know, because we all see separately, they would just look at our note, because once it's up, and then they would just copy and paste that part, which then they can move over into their note. That's kind of how it works for us. But it's like a preform. I think it's called auto text is what it is. I could be using the wrong language, but it's basically like that. And so we've asked about that, and we've kind of gotten they're working on it. They're trying to figure out things. And as more and more clinics come up, then it kind of validates the need for it. So, which I hope Powerform, I know we're talking about Powerform. I thought that would have some sort of way that we could do it or simplify it. So.
Yeah, this is Stephanie. I'll mention it a little bit later in the presentation, but just because the providers are here, I'll do a quick little snippet in. I know, Dr. Gom, you're going to be part of the endocrinology sessions later in mid-February. And I know they're going to go way in depth on that end regarding how we document blood glucose and all that stuff. And in terms of all that information, yes, so there will be some solution that we're hoping to work on at this, and because we are bringing in the VGH diabetes clinic into Cerner at this point, we are leveraging that so that it would be an enterprise-based documentation, so that St. Paul's will have it, VGH will have it, and that design, we're hoping we're going to be able to put it into a PowerPoint, but at this time, we are looking into how we can integrate it throughout Cerner, both in the inpatient and the outpatient side. So I guess the answer is stay tuned. We are working on it. And we hear that there is definitely a need, and definitely Melody has strongly told me about the need. So we hear it, we will look into it, and we'll update you guys when we can.
Yeah, and I would echo what Melody said as well. I mean, we look at, this is what we do like the entire clinic, and so we need a good way to enter it and to look at it. So if you could involve some of us, that would be amazing. Yeah, that would be very helpful. Thank you.
Yeah, for sure. So like we'll see. We'll chat a little bit more about it on the February 14th. I know Keisha and Dr. Gom are both involved in that one. And I think Melody is also invited into that one as well. So, and Richmond folks, stay tuned, sit tight, and we'll get you involved as well.
Thanks, Steph. Kalina, I think we could probably move ahead if there's no further questions at this time.
Sounds good. Thanks, Carmen. So I'll just go quickly into the outpatient quick orders. Just to show you, these are the orders that are most frequently placed by providers. Different kinds of power plans, medications, labs, imaging, and diagnostics. And in terms of referral orders, these are the accept and reject referrals. So once you click on the order, it's going to show in the shopping cart at the top. And I've also put in another referral order here. So this is how you search up the referral orders if they're not in this outpatient quick orders page. So when we go into the shopping cart, this is how you can view the orders that you've placed. And to modify details. Going to the referral to outpatient diabetes program. And this is where you put in the scheduling priority, location, as well as reason for referral. Any questions about placing orders?
Sorry, Brandon here. I'm not sure if you're going to be going over it afterwards, but currently with the diabetes clinic referrals, there's actually and maybe Keisha can also speak to this, how much information she would like or want, but often, there's other things that are sort of included with that. I suppose if it's in CST, that's fine, but like there's, we have a form that checks off, like, for example, they have nephropathy, they have neuropathy, like a list of the medications. I suppose the medications in the A1C can be pulled from CST, hopefully, but is there any other information that comes with the referral, or is it just that one sort of box that you showed there?
Carmen, would you be able to give more information?
Yeah, and I'll also ask Kate to jump in here, but my understanding, and Kate, please correct me if I'm wrong, but there can be a referral note that comes along with the referral. So some clinics use an auto text that has mandatory fields that come with it. But Kate, do you mind just explaining what can make an order more robust and having that required information?
I think you covered the only one that I know about. So, either the referral order itself has a clear set of conditions and a drop down for why they're being referred in the first place, or the additional information that you referred to in the order comments. I have not seen one with the pop-up or with the the information that pops up. I haven't actually seen that myself, so I can't speak to that one. Yeah, and so conditions on them. What some types of things that I have seen is, so the EMG group at St. Paul's is using a very specific set of fields within their order that says this yes no, this yes no, and so you're assuming if something comes through that at least it's going to be going to the right place. So an example of that would be, is this for a patient with myasthenia gravis? And if you say yes, then it tells you that you have to actually send it to VGH, not St. Paul's, that kind of thing. But those are the only things I've seen so far. I don't know if that really helps, but similar to some of the other stuff we've been talking about, like some of these things in the system are possible. We just haven't seen them yet. And so often we take stuff like this and we take it to like a Cerner collaborative call. And so we have consultants from other sites across, North America, basically, and we ask them questions, how they're doing certain things, and they give us responses. And so similar to what was talked about earlier, we would take that back, we would figure that out, and then bring back some solutions the next time that we meet and see if they satisfy.
Yeah, I mean,
oh no, go
sorry.
ahead. I was just going to say, correct me if I'm wrong, but it sounds like you're wanting this referral to have a mandatory note associated with it. Is that correct?
Not even necessarily a note, but like, so let's say for right now, when Keisha gets like, so if Keisha just gets like this one thing here and she has to dig through the charts to look and triage it, that's going to take a lot of her time to really triage and decide when this person needs to be seen. I mean, I understand there's the scheduling priority, but what the referring provider says might be different from what Keisha has triaged. So like with the current referral process, what happens is they get the one-page referral, which has, you can provide a little bit of information about the patient and has like a check off for like, they have all these complications of diabetes. And then they'll always attach, like we require like an A1C and their list of medications. And so, for example, if they have a really high A1C, or if they're on insulin, for example, or other conditions that Keisha, I'm sure, looks at, then she would triage them sooner. So is there a way to, provide, I don't know, so the referring provider can provide some extra information as opposed to like Keisha digging through the chart, like, automatically include an A1C with the referral, or, automatically, or ask the referring provider to, I see you have a spot here for special instructions. But like, maybe list the medications or a checkbox, currently on insulin or something like that. I know maybe Keisha can also speak to sort of what she would kind of like in terms of a referral, but I just think if it's just this right here, it's going to take Keisha a lot more time if she's like having to dig through the actual chart to find all this information.
Yeah,
Sorry.
Yeah, sorry.
I was just going to say one more thing. This is Kate. And so that's kind of what I was referring to about the EMG program. So they would have additional fields within the referral, and it could say something like, do you have a recent A1C on the chart? And yes, no, and it's mandatory to yes. Or it would say, are the recent medications updated? Have they done a recent BPMH? So you're kind of forcing whoever's ordering it to make sure that they do those things before they refer, because it's triggering them to do that. It's not going to catch all of them, but it's probably maybe a sort of a better solution than just this one right now.
yeah, and it's Keisha here. I'll just speak to a bit of what Brandon was saying. So yeah, like just to put it in perspective, I get 100 referrals a month. So for me to dig around in this is going to take me ages, and I don't just have to do referrals. I've got other work to do as well. So basically for us, just like I'd sent to Carmen, and I think I sent it to Ruby as well, it was our tertiary care model, like what we accept for our criteria. So besides that, which is their A1C, I also want to know they might just be on no medication, like Brandon said, and I like, you know, we need to either have them on, they need to be either on 2 medications, like they might have an okay A1C, but are they on 4 medications? Like what are they on? That's important. Are they on insulin? It is important for me as well to know. And also one other thing is important to know, sometimes they're referred to us and they're not here to see, they don't want them to see an endo. They might already have an endo. So they might be referred, that's one of the tick boxes, is that, no, actually we want them to see a clinician. So it could be a nurse or a dietitian. So that's important to know as well. And then also the frail, like the elderly, are they, you know, cognitive impairment, like there's a few things that we have on our referral form, and I think you guys might have a copy of that. If I'm not sure, if you don't, I can send it, but there are tick boxes. It's easy for me to have a look and see, right? And also their language, that's important. Do they need an interpreter? Have they got, just like Brandon said, any other comorbidities? Like have they just had a stroke? Like that's important.
I agree. It's Melody. I agree with Keisha. As we are using this exact format, whenever I get anything from the ER or get anything from any department, I'm going into the note and like searching as to why did you refer, or they'll give a little on the special instructions. You know, they'll give a little blurb about what's happening, but it doesn't give the full story. So I don't know. And then the choice of them picking the scheduling priority, I don't think is relevant to them. It's us who's triaging it. So I'll have a doctor who's like needs to be seen within a week, but they're, you know, newly diagnosed and it's just like been put on metformin. It was an emergency, but put on metformin, and they're, you know, they want them to be seen in a week. And it's just like, well, you put them on metformin. I don't think the scheduling priority is within a week. You get them within 2. But I think that the mandatory fields are just not correct for them. And so but I also agree that there should be a criteria that they can put in so that they know why they're referring to the diabetes center.
Yeah, and sorry, it's Brandon here. I completely agree with Melody. I was seeing your scheduling priority there, and you have like very specific within 1 week, within 2 to 3 weeks, or within 1 month. I mean, I think typically we just will do like routine, urgent, or like, I don't know, I can't really say emergent, but like, you know, within a couple of weeks or something. So like maybe if there's even just a few choices, because Keisha and Melody are going to be triaging this to decide when it's going to be seen. So I don't think I tend to agree with what Melody just said about the scheduling priority as well.
Thanks for everyone's input. This is really helpful as we're still in the design phase. We've taken note of everyone's comments here, and we're going to take this back to the team, and then we will see what we can come up with, and hopefully provide some options at our next session. Definitely something that needs to be looked at. I'm hearing the need from numerous sites here that this referral order needs to be more robust and clear for not only the providers, but those triaging on the other end for, I mean, you know, transition of services is one thing, and then also saving provider and clinician time. So thank you, everyone. Kalina, I think that we could probably continue on.
I think that concludes my demo. Is there anything else that you wanted me to show?
No, I think that's it. So I will take the screen back over here.
Thanks, Carmen.
Can everyone see my screen? I'm going to take silence as a yes. So as Kalina showed a few parts of the actual power charts, I just wanted to show particularly Dr. Guam an overview of our understanding of the provider appointment. So we start with that check-in, virtual or in person, that's done by the clerk. And then the provider assesses the patient and accesses all that information via the ambulatory organizer, which was that first page that Kalina landed on. And then patient chart is reviewed, and that's through the components shown in Power Chart. That assessment or consult is completed. Thereafter, a note is created, any orders and or prescriptions, and then a follow-up order is placed. Are we missing anything that should be captured in this workflow?
It's Brandon here. Just a couple of things, of clarifications. I don't think there's anything missing here, but just to clarify a couple of points. So with the check-in part, especially now with virtual, does the patient have to be checked in via the clerk, or can we clinicians also check them in? Because like, for example, when we're doing phone calls, we're going to call them on our own and then check them in at that point, like with our, on our own. Can we do that?
That's a great question. I don't know if do we have someone from scheduling on the line here, Victoria?
I can talk a little bit about that and what we do here.
Perfect. Thank you.
How it's a tedious process, I might say. So we have, not trying to be negative, but so we started out at the beginning of COVID when COVID hit, and we were doing by phone. And the one thing that I think they weren't, that we couldn't do was that we couldn't check in. So we don't check in, we use the sticky notes. And so with the sticky notes, there's these sticky notes on the side of your ambulatory organizer of your list of patients that tell people that, oh, I'm on the phone with them, so that the other person who's looking at the same screen as you can see that you're on the phone. The only issue with that is if you don't refresh your screen to update people that you're calling them, that person will not see that and then will call at the same time. So it's a lot of remembering of these, like, reminding yourself that I have to update my screen, write it down. And then what we have an option to do is arrive the patient to say that we've got them on the phone, and then the clerks can start checking them in. So that's our process. Again, it's not a perfect process, but that we've asked them, is there a way that we can, somehow make it that we can check them in? But unfortunately, they said that the sticky note is the only solution at this point.
Yeah, unfortunately, certain activities are restricted to certain provisions. So a unit clerk would have different abilities than a provider and or nurse. At our next meeting, we can present a couple different options as to what other clinics are doing with their virtual check-in process. And we can decide on an option at that point and make sure everyone is on board with that.
Yeah, it's also just, to give you a sense of our workflow, like, so someone might be scheduled with the endo and with the dietitian and with a nurse. And so, yeah, there's going to be sort of multiple check-ins, or like, and you don't want all people to be trying to call the patient at the same time. So I suppose if that works with the sticky note, then I guess, that's sort of, I guess, how it will work. But yeah.
There's actually, when we jump back into the system, staff will ask that you show in ambulatory organizer, seen by nurse, seen by provider. So there's different options that you can choose, and that alerts the team members who the patient is currently with, whether that be virtual or in person, and it's denoted by different positions. So that's one option that we could look at in a little bit.
But that only works once the clerk checks them in.
That's
and so the clerks don't know, like we don't, like the issue with that is that when we have them on the phone, you have to do that, letting them know that you're on the phone, which is through the sticky note. because we're not going to run to the front and say, oh, we've got them on the phone when we're on the phone with them. So
Of course, yeah.
so it's still not the greatest process, because then the clerks have to monitor the screen, right? They have to be waiting there like, oh, now they're on the patient. But sometimes you can't get a patient on the phone right away. So you dial in like 10 minutes later. So, and then after 10 minutes, sometimes you don't even get them and they're like, oh, they're not even here. So you just end up finding out that like you can't check them in. And so it's not, yeah.
Yeah, it sounds like that it's a tricky process, but we will present what other ambulatory clinics are doing with regards to virtual telephone appointments, and we'll choose an option to go forward with at our next meeting.
And sorry to belabor the point, but is there like a messaging function within CST? Like, can you have a chat open, for example, with like the clerk, and then say, I'm on the phone with so-and-so, and then they can like, so you can just type it while you're on the phone with them?
So there is not like an instant messaging function, to my understanding. We do have a message center, which functions similarly to an email, but you can make that a part of the patient's chart. And we can certainly demo that at our next session. But anyone else on the line, if I've missed the instant messaging function on Cerner, let me know, but I don't believe it's there.
No, that's just on Epic. Not Cerner.
Yes, yeah, I used Epic before, so sort of some of this stuff that I'm saying is kind of drawn from Epic. Yeah.
You can't, again, that sticky note is like kind of instant messaging, because once you write a note on there, but the only thing is you have to hit the refresh button, right? Like, so anything you input won't go on screen until you hit that refresh button. And that's the part where I think a lot of our team kind of forgets once in a while, especially once you start getting into it, you forget, oh, I had to hit the refresh button to let them know that I'm calling them, or I'm talking to them. Or again, it's simultaneously, right? Like at 8:34, both of us are writing, calling patient, hit the refresh, and both at the same time to see 8:34, RN calling, RD calling, and we both end up calling and only one person gets it. So
I think also the function you say seen by provider, seen by nurse, only one person can put that. Like if I put it in, then the nurse comes along and sees somebody, they can change it to seen by nurse. So that the sticky note is still a way for a clerk to see who has seen the patient, not that tab.
Okay, thanks for the insight. Is your clinic using Tracking Shell at all?
Sorry,
no, we aren't using Tracking Shell, but we asked about it, or someone from another unit was like, why don't you guys use Tracking Shell? We were just not ever shown how to use it. And it was not an option, I think they said. I don't know. I remember talking to CST and they were like, it can't be an option for you guys. I don't know why, but if that changes, that would be, I've heard that that's a better way to figure out how things are going.
That's something we can take back to the team, and we'll have discussions about that.
And sorry, I just had one other thing. I'm sorry that I keep bringing things up, but just because there's a lot of things, a lot of steps in here. So just in terms of the discharge, so you have and documentation orders, you have your consult note, orders and prescriptions. One other thing, I don't know, maybe there's an easy way of doing this, but like, for example, we might give patients like a handout at the end of the visit. And I know like Epic, for example, has a way to do like a post-discharge, post-visit like handout. And the one thing that I'm sort of thinking of is besides orders, we sometimes give patients like an insulin sliding scale. So we might give them like, doses of insulin to take with different blood sugars. And that would be kind of tedious, I think, or difficult maybe to put as an order. I'm not sure. I don't have much experience with CSD, but we sometimes would, like I personally, if I was in clinic, with the current system, I would just type it up in a Word document actually, and just like give them a sliding scale to use. But I'm just wondering if there's the ability to do something like that in CSD, or that can be sort of incorporated into like potentially part of the post-discharge like documentation or handouts.
So sorry, just to clarify, so are you you're not referring to printing out the prescription or order itself? This is more of an educational tool for the patients, is that correct?
Yeah, I don't think anyone would enter that as an order, because like, for example, you'd enter because the order would be like a prescription, right? So like you'd enter a prescription for like insulin, let's say, you'd enter NovoRapid, let's say. But then when you put on the NovoRapid prescription, you just say use as directed. But then the patient takes, so that goes to the pharmacy or fax or whatever. But the patient takes out like a document that has that they just use, they keep it at home, and, you know, on their TV, or sorry, on their fridge, or like on their wherever, and they use that to help them dose it. So it's like instructions for the patients, essentially.
I see. And so there's certainly the free text note option, where you can print to PDF and provide that to the patient as sort of a post appointment take home, if you will. That free text option is there.
Okay, I think it might be useful. I don't know how others feel, but if we had sort of like a standardized kind of like insulin sliding scale that like we could fill out and have in, and so it's like, I guess, a free text or something, or sorry, an auto text or something, where it just like creates a table in the notes, and then we can just put in numbers in there. If that was at all possible, I think that would be super helpful for providers to sort of, instead of having to create a table every time and having to say, you know, oh, with breakfast you take this dose, and with lunch you take this dose, and dinner, and then having to type all that in there. I think that would be very, very helpful for providers. And I'd be happy to help make something like that, or like create it as an auto text or whatnot. But I think people would definitely want something like that.
That's a great takeaway. We will we'll chat further about that. Thank you, Dr. Baum. Anyone else on the line have any thing to add to that?
Hi, it's Keisha here. I just want to just like, I'm just looking at your provider appointment, and then where is it in there? It says follow-up order placed. So is that where, what about like booking their, would that include booking their next appointment?
Yeah, so the follow-up order would have a frequency in it. So whether that is Q3 months or 6 months, we can explore the orders a little bit more, but it would, the order would house that scheduling requirement, and that would be sent off to your unit clerk.
Okay.
All right.
I'm going to keep driving the slides here, Steph, but you take it away.
No problem. Thank you. All right, so thank you for everyone for bringing those pieces in. I think with the St. Paul's Diabetes Clinic, I think a lot of these actually was mentioned before, and we are definitely hoping that with VGH, we can bring some more of these pieces in as much as we can. I know, like, for example, the insulin pump things, and also just the documentation of blood glucose and all that stuff. We're hoping we can provide you guys with a little bit of a better solution in the upcoming meeting. All right, so the next session we're going to chat about is going to be talking about a power form design. I know I have mentioned that to a few of you guys here, but also I'll give an idea of what the power form is. And in terms of our providers, Dr. Baum, Dr. C, feel free to stay if you are interested. This would be more of a dietitian / nursing power form at this time. And the endocrinologist piece would be more discussed on February 14th. Okay. So feel free to hop off if you need to. If not, feel free to stay and listen in as well too. So this one, I think Melody, Keisha, you guys will probably be a lot more giving us a lot more feedback on this part for sure. Okay, just to give everyone a general idea of, let's say, an initial assessment, when the clerk checks in the patient and the appointment starts, the nurses, the RDs, and the endos can all access the patient via the ambulatory organizer. And in terms of the assessment, I know that both St. Paul's and VGH does a bit of like a rotational arrangement where they would take turns seeing the patient and also taking turns seeing the endo as well. So a lot of that would be, in a sense, can be done in Cerner. And then in terms of the nurse and the RD specific, there are a few ways we are documenting at this time. And I know it is a little bit all over the place. I think Melody can attest to that. There are places in the section called iView. There's a section where you can put your own information into a documentation, so kind of like a text documentation. And then there's also your overview page, what we call the M page. So all three of those areas are places you can chart. And what we are trying to do or aiming to do today is to get a conversation started to create something where it can all come together. So rather than going to iView for the nutrition history and then going to the medication section for the medication and then the BPMH section for like and whatnot. So you're gonna all kind of put together specifically for the nurse and the dietitian. Okay? So the provider will have a little bit of a different view. And then anything else that requires documentation and teaching and all that stuff will be able to be documented or put into the Power Form if necessary. And then referring to, let's say, the social worker on the VGH perspective, they'll be able to do that as well. Okay, so that's the gist of what we're going to talk about. So in the next slide, this is basically what is a Power Form. So I know that that's a bit of a Cerner language. You might hear Power Form or ad hoc charting kind of interchangeably, but basically the ad hoc folder is a filing cabinet of a bunch of forms. And Power Form is basically your assessment form or your any specific forms that you may have on your paper. So like, let's say both of the clinics at St. Paul's and VGH and at Richmond actually all have some sort of assessment form. Really, what Power Form can do is try to mimic what you guys have in the paper form and focus more so in the areas that are specific to your needs and your clinic's needs. So for example, I have a very generic example here. The Power Form can be separated into several sections. So the leftmost section, you see kind of like a menu bar. That menu bar is what we're going to kind of start discussing. Like, what do you guys want in this stuff? How do you want it to look like? And then, so each of the section will be a bunch of different areas you can chart on. So in the middle area that says general information right now, that's kind of where you're going to put in all that information. So you'll be able to put in, for example, are they accompanied by anyone? So this is just a general information. So you're not going to get the diabetes specific stuff, but just to give you an idea that you can put information for general patient information or specific. There are several ways you can document things. You can document by just typing into text. You can document by having multiple checkboxes. So the square ones are the multiple ones. And then you also have what we call the radial buttons, which is the circle buttons, where you can only check one. And then all three of those we can mix and match into what we call the Power Form. Now, in terms of this Power Form, there are two main things. So anything with a yellow background is mandatory. So every time you open this Power Form and you chart on it, and that section is yellow, that means you will have to document something on that. Anything with a white background is optional. So let's say if you're using this assessment, not only in the initial assessment, but any follow-up assessments, and you want to use the same form, keep that in mind. Think about that piece in terms of what you want things to be mandatory every time, and then what you want to be optional. at times. Okay, so this is kind of the idea of a power form. All right, next slide. So just to give people a background of where this came from, this ticket is actually what we use to keep track of what we need to do, kind of like our to-do list. And in terms of this particular ticket, actually started when St. Paul's went live. And what we wanted to do, or what our goal was to create a power form so that it mimics current assessment forms as much as possible, and also be able to provide the clinicians a opportunity to move everything into Cerner and PowerChart as well. And also, the intent was that this power form can be used by the nurse and the dietitian at the same time, because what we see is a lot of the initial assessments, the nurse and the dietitian does do that together. However, we also still want to keep it in a way that it can be separate as well. So we want to give that flexibility to you guys to use this power form as much as possible. Because we understand that there's RD only sessions, RN only sessions, endo only sessions. So we know that there are all these different sessions you guys have. So we want to make sure that this does meet your needs of the clinic. So that is kind of the backstory of it. So I'll just move on to the next slide. Now, I know there is a lot of discussion about insulin pump. You guys are very interested about documenting insulin pump onto Cerner. Now, I just wanted to give everyone just a background of where we are at in terms of insulin pump documentation. Because we are also linked to any inpatient documentation, and all this stuff can be linked all together. And so what that means is what you see in the patient's chart will include what they had inpatient and also anything ambulatory and outpatient. So what that, so in the inpatient endocrinology side, there is a lot of work on prototyping and creating an insulin pump documentation standard. Now, at this time, what we have to do is to make sure professional practice is okay with all the policies that we're going into. How are we going to document how some of these sliding scale blood glucose is going into. Also thinking about how we're going to be able to see all this information. So I know there was a lot of questions about, oh, what about blood glucose? What about the insulin? How are we able to kind of create that record so that we can have an adjustment record? So just so you guys know, it is in the works. For sites that already have Cerner, and I know last week I was talking to Melanie and Annie about this, they might start seeing something called a diabetes management workflow. That is put on live for the children's program, and we're hoping to leverage that so that we can use it for the adult side as well. So summary, it's in the works, and both for the blood glucose and also the insulin documentation. Stay tuned, but we're not gonna, unfortunately, we won't be able to talk about it at this particular meeting, but we hope to provide updates in the near future, okay? So just to give everyone a heads up on that. All right, so let's get started.
Sorry,
Yeah.
Stephanie, can I just ask a question?
Yeah, for sure.
It's Keisha. So when you said it's in the works for the pump one, are you also going to have it in the works for the sensor documentation as well, the continuous glucose monitor?
That's
what will need to be in the works as well, because that is going to eventually come into being like a standard way of how people are going to measure their sugar, and especially as inpatient as well, it is coming. So that might need to be in the works too.
That's a very good point. What we're hoping is once we design kind of the backbone for the insulin pump, that we could use a similar backbone for the sensor information as much as we can. And that's why right now what we're alluding to is we're trying to design it for the inpatient setting, and also use that for the outpatient setting as well. So yes, we are aware that sensor data is getting more and more common, and it's probably the way to go basically. What I'll say as a disclaimer is having Cerner connect to some of these programs that collect the sensor data, that's going to be a very tricky part, to have something connected together and have them talk to each other. However, for us to document sensor information should be in the works. Okay, so just to keep that clear, that it'll be a bit hard for us to, like, let's say, talk to Deb's comments on that. But however, we can provide something to think about and design once we have more of that documentation of policies in place.
This is Maureen. Another platform is Gluco.
Oh, yes.
Yes, that's we're using one more of.
Okay, awesome. So yeah, so if we have multiple platforms, it is a little bit harder for us to talk to these platforms as a CST language. But what we can do is we can make it so that it's easier for you guys to talk to. Okay. All right. So kind of thinking back, tracking back to your initial assessment form. Okay. So I'm thinking the interdisciplinary assessment form that some of the clinics may have, or the overall initial assessment form that the other clinics may have. So thinking about that particular form. Okay. Now, what we're going to do is we're going to think about some of the sections that that you need. I'm going to use the word need, must have, to document, and then thinking about who documents what. Okay. Is it the nurse that's documenting it, or is it the dietitian that's documenting it? And then what we're going to try to do is match it up to what's available in Cerner. Okay, so for those who are in a live site, you might see some of these things look extremely familiar to you. However, for those who may not have Cerner at this time, this might look very foreign to you guys. So bear with me, I'll try to explain all that little pieces together. So what we want to do is, for all the clinic staff, we want to try to get as much of the information as possible of what you guys need in that power form. And for those who are practice leads that may join our meeting, let us know if there's anything that does not comply to professional practice standards. Okay, and on that end, so what I'm going to do is I'm actually going to share my screen if that's possible.
Yeah, I'll stop sharing now.
Okay, thank you. All right, so. All right, let me know if you guys see my screen. Give me a thumbs up. Awesome, thank you. All right, so this document, I'm just using Excel as a precursor, but basically what we're trying to create is a visual representation of the power form. So what I did with you guys was I actually went through some of the VGH forms, and then I also have access to the SVH forms. Richmond folks, if you don't mind, can you send me your interdisciplinary assessment form? I believe my email will be in the meeting invite. So feel free to send it to me and I'll make sure we can include it for now. So what we did was something called a crosswalk. Okay? And just to give you guys an idea of what we mean by crosswalk, I'm sorry if it looks very crowded. Okay, so in this Word document I'm showing you, what we were trying to do is to make sure what you guys have in the assessment form is available in Cerner. So that's basically what we call a crosswalk. As you can tell, it is kind of all over the place. You have something in this section, you have something in that section, some similar to what I said. So what we hope to do is to create a page where all this is kind of in one section, okay? So let me go back to here and I'll give you an example. So the example is, for example, the first section of this power form can be talking about, do you have their consent? Very basic appointment like start of appointment information. Chief complaints, reason for referral, not diagnosis, because that would be an endo thing. But chief complaints, reason for referrals, we can definitely put into that stuff. And language, barriers to communication, we can document that in addition to any live Cerner patients would have that information in their charts already. And then also we have some other areas such as diabetes concerns, blood glucose concerns. So all this is kind of like your summary page. And then we can also put, for example, a plan and see how what we need to do. And that would be documented into the patient's chart. Okay, so this is, for example, the summary. And I'll give you another example. For the other example you might see is allergies and medications. Okay, so this one might look very similar to the allergies and medication section of the power chart. But what they can do is they can basically just pull that piece and put it into one of the tabs in the form. All right, so rather than going to a separate section of the chart, keep clicking and then add and all that stuff, it's basically you can open one window and it will be there. So for example, allergies, you can document the allergies here. If the endo is not doing the medication reconciliation, and the nurse might be doing part of that stuff, we can also have that put out there as well. Or if they have seen the endo or have been recently discharged and has all the medication, it will be pulled out here as well. So you don't have to go to your assessment form and go check. They have metformin or they have a sulfa. In that sense, you don't have to do that checking anymore. Okay, and it will be all there. Okay, and then I'll do one more example. So another example you might see is anything related to their social history, procedural surgical history, and also family medical history. Now, in that sense, you can add in, let's say, how many people they're living with, or do they have the proper supports? Are they working? How are there concerns about what they do, or the way, like, is it labor work or desk work or whatnot? You can add all that stuff and it'll be in one tab. Okay, so similar to how you guys have like your own boxes in the assessment form, there will be one tab. Okay, now there are definitely areas where there might not be a specific section to the diabetes clinic. For example, the eye exam. So a lot of the times you guys might have to ask them, oh, have you guys had an eye exam? Or do you guys have an ophthalmologist following you guys? So sometimes you might not have a specific area to document that stuff. So what in that case is you can always use the other section as an extra, or just let us know if that's like, oh, we really want to put that into a specific section. We'll see what we can do and where we can put it and see if it can match us up. If not, then there's always the other section to document that stuff. Okay. All right. So before we proceed, is there any questions about what a power form is, how it can be beneficial to you guys, or any other questions about that? Thumbs up if you're good. You guys are good? Okay, awesome. So what we'll do is this Excel spreadsheet is basically built by combining what is available as an ambulatory assessment power form on Cerner, plus what you guys have on the assessment form as much as possible. Keep in mind there are some sections you guys might not have at this time. And I'll note them down and say, hey, we don't have this section, and then we'll see if we can build a part of that as well. Okay, so when you guys are ready, so what I'll do is I'll go through some of these and then let me know what speaks to you guys. So like, oh, is this a good thing to add? Is this not a good thing to add? And then I'll make notes of that. Okay, so how are you guys feeling about some of these things you're seeing in the summary page? So like consent obtained, chief complaints, reason for referrals, accompanied by if it's an in-person, just so to keep in mind, you're gonna have the virtual and in-person assessment done in the same power form. So there will be some sections that may be applicable to in-person, or some will be less. So how are you guys feeling about some of these? And yeah, speak up about anything you're seeing.
I think my question here is, if we put in a chief complaint, would that help with our statistics on, pulling people up who are type 1, who are versus type 2, who are on a pump, not on a pump? Like, I think that's the issue that we're having now, is that we don't know who's who with our patients, right? Like, there's no way on their document to tell us that they're the type 1 patient on a pump. So
yes, yeah. So ideally, if the endocrinologists have seen the patient, we do hope that the endocrinologist would have put that in, but I know that might not be the case for us.
It's not happening at all.
Yeah, so if that is the case, then you can put it in chief complaint or reason for referral in any one of those, and then it should be able to pull up. I know our design expert, Richard, is also on the line, but let me know if I'm off. But I believe chief complaint should pop up in the M page. If you have it.
Yeah, as long as the chief complaint, and sorry, this is Rich. As long as the chief complaint is the same field, if it's populated at any point, it would pull up right in the end page. We can also do the same for the power form. So if it is populated by the provider, or the dietitian, or the nurse, it would automatically open up into it automatically would populate to that section or that component.
Okay.
So in other words, it would be what we call face up. So you'd be able to see that without entering into the power form.
Okay, so yes, so I think that would solve some of your concerns about whether or not you know if that patient is type 1, type 2, gestational, or has a pump or whatnot. So that would be your place to put that information in.
Okay.
If the provider did not do that.
Yeah, the providers aren't going to do that often. I think it's going to be the nurse and dietitian to put that in. So, but I just wanted to know will that make a difference for us? Because right now we're, the clerks are making notes for us on who's who. But if we don't write a note, then we don't know who this patient is,
Right. Yeah, so I don't think we can sort by like chief complaint or whatnot. But when you have something booked and you see that patient, it'll show up. Sorry, Richard, I cut you off.
No, the only thing I was going to add, if the provider decides they want that chief complaint, they'll always have the ability on their end page, and they'll re-sign it, and that will put a new timestamp, even say that they updated the DTF, the field.
Okay. Yeah, so let me know if you have any other questions about any of these sections, what you're seeing. So yeah, I guess my question to you guys is, do you want your plan and recommendations to the patient as part of the summary, which is basically the first tab, or do you guys want to see it more like their own tab kind of thing?
I think it'd be better as its own tab.
Okay. How's everyone feeling about that as well?
We're talking about the recommendations, right? Like
yeah.
Yeah.
Yeah. So recommendations or things to monitor, to evaluate, and all that stuff. Be it nutrition, medical management, all that stuff. We can definitely, we can make a separate section.
Yeah, that should be separate.
Sure. No, not a problem. So right now I'm just putting examples of what is available in Cerner in terms of what you guys can see. Obviously these to what you guys need. Also, do you need the most recent hemoglobin A1C in the summary section, or do you want it in another section?
Summary with labs. Like it'd be good if it was all together with labs instead of just labs all over the place, like one section with all labs and then blood work, their blood sugars. Like I know I see that it says here like high B blood sugar, low blood sugar. Like we don't know unless we have the numbers in front of us. Like I think,
right.
You know, if we can have like how Dr. Gom was explaining of an area, we can enter all that information in.
Okay. Now, Richard, correct me if I'm wrong. Labs, are they able to be pulled into a power form or no?
No, we would recommend that you use the lab component on your workflow web page. And from there, you can see all the labs you need to. And another benefit of that is you can also see filtering. So you can filter down just your A1C or diabetic labs. So you don't search through depending on which patients and the severity, sometimes you can have hundreds of labs. This one could narrow it down for you, but it can be pulled into a power.
Okay, perfect. Okay, awesome. So just to keep that in mind that like we can't pull labs, but if you need to document something, you can have something like this, like similar to this one most recent A1C kind of thing. Okay. If it's not showing up on the labs section, just so you guys know. Okay, so let's so basically in this summary we'll focus more on like chief complaints and language, and if there's anything related to like who's part of the family or who they were coming with, and we'll kind of keep those things there. Is that okay? Thumbs up.
Can we add anything with kind of the phone call, like it's a phone call instead? Because the majority of us are virtual right now, not, you know, like it'd be good to know that they were not they were on a phone by their daughter instead. I don't know.
Okay.
Like, I think that there's something should be added, that it was a phone visit versus an in-person visit.
Yeah, like the type of visit. So we do in-person, phone or Zoom, like or virtual. That's what we usually tick. And then it would be nice as well to have kind of like what the person, like that's the visit, but what do they prefer? Like, because some people we might be emailing them stuff as well. Like, I mean, you know,
so like a preferred communication method.
Yeah.
Yeah.
Okay. So and then there'll be like things like, I don't know, email. Do you want this as like more of an open text or keep it like the radio buttons?
I don't. I think that maybe points, like we don't have to write it, because I think we know
Yeah.
whether they want email, phone, in person. There's no really other method.
So kind of like a multiple choice.
Yeah, or like those radio buttons, right?
Radio
Like
buttons? Okay.
radio buttons or check marks, because sometimes they might like prefer email and telephone.
Yeah.
Okay. So yeah, so radio buttons, keep in mind that it's going to be one choice only. If they want to do more than one choice, we'll need that like multiple choice boxes, basically. Okay, so just keep that in mind. So yeah, so these ones will be the multiple choice boxes, and this would be the radio buttons I'm talking about. Okay, all right.
Hold on.
else?
Yeah, there's another question I have. So for the language side of it, even though it might be what language, but we also might need to have interpreter.
Yes.
Because you know what I mean? Like just language doesn't tell us much. Like they might require an interpreter. And then also, what if patients are deaf as well? Because that's an issue for some of our patients as well. So that needs to be an option somewhere in there too.
Okay.
Agreed.
So this one, that's a very good question. Now I'm sorry, I have to go back to you, Richard. Would that be pulled into the power chart on the top banner, or would that be more something they would have to document?
This is Carmen speaking. You could also add, there's functionality within PM conversation. That's a potential that you can add like an alert to the top of the patient chart.
Okay, perfect.
I'd have to look into the power chart to see what sort of alerts live there, but we can look into that and see if that meets the needs.
Language required. I know that in the when we put in the appointment, that is one of the yellow mandatory sections to fill out in PM office for chat book. So that could be something we can look into, we can pull into. So communication barrier to specify. Okay, anything else in this area that you're thinking would be nice to have or would need to have? Change that. No, okay. If that's the case, we'll move on. So problems and diagnosis. So this one's a little bit tricky. Diagnosis, again, it would be a provider thing that will have to be filled in. My understanding is you can fill in the problems list. Is that correct?
Yeah, that's my understanding as well. So providers fill in diagnoses, whereas other professions can provide problems for this current visit.
So these two sections would be a little bit harder to change, but I guess my question is, would it be helpful to have these sections in the PowerPoint or not so much?
I think if we're not able to fill out diagnosis, then we shouldn't have it in a power form as a nurse and dietitian. Like, I don't know, like if there's no reason for it there if we can't fill it out. Problems, I mean, our chief complaint is going to always be the same. So I feel like the problems are kind of.
Yeah, so, and the thing is with problems, you're going to get more than just the diabetes stuff as well too. So you might see like hypertension, asthma, gout, all that stuff. Okay, so if that's something that's helpful, again, this is a lot more, like you have the chief complaint, but you also have a lot more discrete information provided.
Just like a medical history almost, kind of?
Kind of, yeah.
Yeah, okay.
Yeah. So would this be something that would be nice to include? Because this would be pretty much a pull from the chart.
Steph, I think that we've actually told them backwards. So diagnosis would be the issue being addressed in this current visit, whereas the problem is more your health history. So that's the part that's being filled out by the provider. So it may still be advantageous to have that information pulled in if the provider is indeed filling that out, because you'd have that nice view of that health history, whereas the allied and nursing could fill in the what is being addressed this visit, and our mistake on mixing those two up.
There's several patients, this is Maureen, we see patients that are not seen by a provider.
Okay. In that case, yeah, so not every patient that comes in will see the endo, basically, as well too, right? In that case, I think what we should do is maybe just keep the two sections, because ideally, this problem list, as these patients become more and more frequent in Cerner, this list would be a lot more complete. Maybe in the beginning, you might see more that are empty and you have to fill it in kind of on your own kind of thing, or the provider has to fill it in. Okay. All right. Same thing for allergies and medication. This would basically just be a simple pull from the chart. Allergies, that will be able to document. Medication, it could be pulled from several areas. It can be pulled from PharmaNet. It can be, you can document it on your own, that kind of thing, okay? But anything related to prescriptions obviously will be a provider thing to fill out. Okay. I'm going to skip over this one, but I just wanted to let you guys know that we are aware that we are looking into glucose monitoring and all that stuff. And I know Keisha did send us a few extra things this week, and what we'll do is we'll put them all in here so that we have a place to show when that piece is ready to add on to our program. Okay.
Yeah, I'll just say, Melody, I just basically included for the CGM, like I was saying, to include like the time in range, the CMI, like that kind of stuff in there. You know, the very high, very low, the percentage. That's what I was trying. I said to them to include.
Yeah, no, that's perfect. That's exactly what I would be looking at too as well.
Yeah. So what we'll do is we'll add them in so we know that these are the things that you guys want in there, and then once we can build it, we'll put it in. Okay.
So records. Sorry, it's Maureen. Records the amount of reading. Maybe that could be a part of it too.
Sorry, you cut in and out. Do you mind repeating that?
Some of the patients write down the carbs they're eating. So sometimes the average carbs is another thing you put in the charting.
So like a bit of a carb counting piece.
Yeah, like the average carbs per day is also listed on those reports.
Okay. At this time, no. We didn't see that in our initial the initial assessment form, so we did not include that at this time. But let me put that down as a note.
I'm talking about pumps and for sensors.
Right. Okay. So average carb per day. Okay. So I'll put a note down here for myself. So that we can include it. So yes, anything glucose and insulin monitoring, I'll add on to here. And what I'll do is I'll actually send this Excel document for you guys, and then just plug in your comments for us, and then we'll kind of consolidate all the comments.
Can I add something to the carb?
Yeah.
Rather than the total carbs for the whole day, as a dietitian, I'm very interested in the carb per meal and snack, because that's what's most responsible for raising the sugar immediately after the meal.
Okay.
So down.
Sure.
Thank you.
let's put that in for there. All right. Yeah. So I know that there is an auto text note for dietitians to do a little bit more of the counting and kind of documenting for insulin pump, but we'll see if we can pull that in as well too. Okay. So in terms of the history, this is what I showed you before. Social history, procedural history, that would be most likely auto-populated once this patient is live on Cerner, but you can also add. And also any family history, like family medical history and all that stuff is available as well. Would these sections be useful?
We use it. We use the family history occasionally and the procedures for eye exams. But if you're going to make a separate section for eye exams and immunizations, then procedures don't really work for us.
Okay, so the thing about immunizations is it will have to stay as a separate section in Cerner because I believe it has to be pulled from somewhere. But it's just on the side menu bar saying immunizations. Typically, do you guys add, or Richard, I think you want to say something?
Oh, sorry, I was going to add too that the immunizations will also be available in their workflow, which could be a little bit more compromising list in the power form section that we could pull.
Okay, I'm just going to put, yeah. Okay. All right. So would you guys typically add any immunizations, or do you guys just more so ask?
Well, we might.
Yeah.
Go, Melody.
No, yeah, we normally just ask if they've gotten their COVID vaccinations and their flu shots. Sometimes they're, we'll ask if any other immunizations that they should be getting. So we just ask if it's yes or no. We're not really inputting any kind of information other than like making sure that they get it.
Okay. Anything to add, Keisha?
No, that's what I was going to say, because especially when patients will ask us, like especially diabetic patients, should I get my, flu vaccination? That's one of the things we would always recommend. And then obviously the COVID-19 vaccination.
For sure, yeah. Okay. And I believe they'll probably have to go to a public health unit to get their immunizations updated on Paris anyway, because I believe Paris would be the main immunization record area. But okay, good to know that it'll be mainly just to ask about COVID flu shots.
Yeah, we're not administering it.
Okay.
So we're just asking if they've gotten it and providing education on it. So
okay, gotcha. I'm just gonna put this in here so that I have it with me. Okay, all right. Measurements. So in measurements right now, I have shown weight, height, and that kind of thing. Right now, just because of how it is, the dosing weight is put mandatory, but we don't have to make it mandatory. Dosing weight is more of an inpatient terminology. And also for anything related to virtual health visits, you might not get an actual weight per se. So we did put down, say, weight estimated or anything like patient reported weight, that kind of thing will be available in that section as well. Now, in terms of vital signs, we have some vital sign options here. Would these be helpful to have in the PowerPoint?
Again, keep in mind, these aren't mandatory fields. They're just there if clinically indicated for that visit.
I think just regular blood pressure for us. We don't really do unless they're coming in with some issue with that, and then we do it. It might be but it's not something we do all the time, that we're getting them to stand up, lie down.
Yeah, the same for us for VGH. It'll just be the blood pressure. We don't usually, honestly, we're outpatients. I wouldn't even take someone's temperature here.
Yeah.
You know what I mean? Like it's not kind of like a standard thing. Even the SATs I wouldn't necessarily do if I felt they were compromised respiratory wise, then they're not going to be staying here. They're going to the emergency.
Exactly. Yeah.
department.
Okay, so it looks like Richmond agrees that just a simple blood pressure would be good enough. Okay, gotcha. So let's keep that cleaner and see if we can clean it up a little bit. All right. Okay. But otherwise, in terms of measurements, weight, height, blood pressure, anything else?
I just wanted to make a note on the vital signs. It may be pertinent to keep the availability of charting a complete set of vitals in the case that you would need to. There are certainly other sections within Power Chart that you could chart comprehensive vitals, but recognizing that BP is probably the only thing being taken, but maybe just think about circumstances where you would want that comprehensive set and if it would be good to have it there. It's already built out, so it's easy to pull it into the form.
Okay, thank you, Carmen. Yeah, so let us know. Don't worry, you will have time to think about this. This is not your final answer. And we'll definitely present it again in the follow-up meeting, just so you guys are kind of all aware and see if there's any other students who would like to provide input. Okay.
Sorry, I just had another question back to the weight. We also might weigh them, like we also should have an option with shoes or without shoes. Do you know what I mean?
Would that be something you would like as like a radio button, or would this be like nice to have a little comment box beside the weight saying like, oh, did they have shoes on? Did they have their jacket on? So you can add on to those things, or more so just shoes specifically?
Shoes is the main bit for us, but
Okay.
I don't know what Melody or anyone else thinks.
Maureen? I don't know, that we don't really check weight often, but it's not a mandatory field as well, right? Like it's not.
No, exactly. It's not going to be a mandatory field. Just to think about when we are pulling that data, just thinking about how you want to see it and how it's going to be pulled. Again, so you can think about just a quick radio button, shoes on, shoes off, or it can be just a comment saying like, oh, are they boots? Are they slippers? Are they flats? Like that kind of thing. Up to you guys. There are options to do that.
Just another thing, sorry, Stephanie, just again, back to the blood pressure side of things. For the blood pressure, so you might want to have in there whether they're sitting or standing, like, I mean, because sometimes they are sitting, like, I mean, that can, I don't know if that should be an option. And then the other thing is should we have somewhere in there that actually says goal? Like it's not saying anything, but that's the goal for the blood pressure, is that it should be, 130 over 80 or less, you know what I mean? Like, should that be in there or not? We have that on our form, but I'm not sure. It's just so that people know when they're taking their blood pressure. It could be some other clinician that actually this is what it should be, but yeah.
Now, my question to you is, do you want the blood pressure goals all in a goal tab, or do you want it right beside the blood pressure?
Right now, like if I'm saying how we would chart it, it's right beside it. So we'd write down what the blood pressure is, and beside that in like sort of like brackets is like the goal. Yeah.
Okay. And the other thing is, do you want it to show up in both areas? Like we said, we can pull data into different places. So do you want the blood pressure goal to be in this section, the measurement section, and the goal section at the same time, or not so much?
Well, I would probably, it should be in the measurement section, just so it's really to prompt that clinician that, yeah.
I agree.
Okay, awesome.
Can I go back to the weight? I guess if somebody else wants with shoes without, but our fancy electronic scale is now in the doctor's office. So they're the ones, if somebody can wait, that's really good.
But we also don't have a fancy scale. We also have an old scale. So we don't have a big digital one.
Oh, well, that was one of our presents was redesigned.
So what I'm thinking is, again, just thinking about how we can pull and grab data. If the provider does input the weight into it, we can make it so that it shows up here as well. If it's a nurse or a dietitian that measures the weight, they can put it in there in this PowerPoint.
Okay, Melody, probably what's going to happen is providers not going to put it in that box. Is that correct, Melody? They're just going to put it in. No, there's no way. I don't think so.
The providers are not going to use these power forms unless they know about these power forms and they're taught to use it, but they're not. They're going to use their own notes. So they're not going to be entering any information. This is more for like the nurse and the dietitian to enter information.
Exactly. Yeah. So that's only if, let's say, if they have one and they put it in, it can show up. Or if they put it in their auto text, unfortunately, it won't pull up. Okay.
They don't even use the sticky notes, so I don't think they'll do this.
Yes, it sounds like there might be a bit of a discussion of education that we'll have to put into place. Okay. All right.
Sorry.
Yeah, for sure.
I had another question. Just because I'm
worries.
Sorry about this. Just because I was looking at the nutrition assessment form that the dietitians used for the weight as well for their form, and which isn't included in this bit, so I'm not sure. So they also have like reported gain loss, like, you know, over how many months, like that's not, so this is just the weight bit, but I'm just saying that's what they also capture on their form.
So yes, so because this is going to be a dietitian and nurse combined power form, I'll just give you a really quick idea. The nutrition assessment will be a section in this form. So therefore, they can actually put, the dietitian or the nurse can put into that box when they need to. Okay, so just to keep that context, to keep that in mind. Now, I know it's 11. We have gone through this for 2 hours, and just thinking about the use of our time, we do have a few other things we wanted to go through, and we also have the inpatient nursing piece to go through as well. Do you think everyone needs a break, or we'll be able to kind of chug through until noon kind of thing?
I just need to run to do something quickly, and I'll be right back in like 2 minutes. So
Yeah, for sure. Why don't we just take a 5-minute break now then? And then we'll come back.
Like 11:07, let's say.
Yeah, so let's come back at 11:07. All right, thank you. And we'll see you guys in 5 minutes.
We'll just give everyone another minute here. Looks like Keisha's not quite back yet.
All right, so for those who are back, let me know if when you guys are ready, you guys can give me a thumbs up or just put it on the chat or whatever. We will see it. I think Keisha's not back yet, but okay. So what I'll do is I'll go through probably, let's see, two more sections, 2 to 3 more sections, just to give you guys an idea. We'll spend maybe about like 15 minutes more on this discussion. And what I'll do is I'll send this Excel document to everyone so that you guys can give me all the comments you want. And then we'll bring it back and explain it to you guys and kind of see what we can mock up by then, okay? All right, so in the nutrition assessment, I know that we have a few dietitians on the line, so feel free to chime in on this piece. What I did was I basically went through your nutrition assessment form, plus what you add into the nutrition assessment piece in the overall assessment form. And I kind of combined them all to what we have already in Cerner. So what we have in Cerner already is what you're seeing here in terms of what's available. So what you'll see some that are kind of like a drop-down bar. Some of them will be text box, especially anything related to diet history. And this section could be useful for anything from initial to follow-up to also anything to insulin pumps or any of that stuff as well. So you can definitely use this section once it's built up. I did include physical activity as part of the nutrition assessment piece because based on what I saw in the assessment forms, there's only one little section about physical activity. So I just included in the nutrition assessment. So you guys will be, just so you guys are aware. And then there's also a bunch of different things such as you can look into, okay, nutrition education that you're gonna provide. And then for those who have are in a live site already, you'll know that the nutrition intervention and diagnoses can be filled out, and you can put in several diagnoses, interventions, and whatnot, and you can always document if you're monitoring, if it's completed, and all that stuff is available as well. Now, I guess in that sense, I just wanted to get how you guys feel about it really quickly, and then we'll go in. This exercise assessment, another area in nursing. So this assessment can be filled by nurse or the RD. So the nurse can go into the physical activity box and write in as well too.
Just a question, Stephanie. So for the, because obviously we have just nurse consultations as well. So then the nurse is going to have to know to go into the dietitian piece and then write the activity in there.
It'll be it's called just nutrition assessment. It'll be a tab on the PowerPoint.
But what I think is like, like personally, I think the activity piece should be close to where the hypoglycemic piece is as well. Like, I don't think it should just be in the dietary piece section.
Okay.
Sorry.
Okay, yeah.
What do you think, Melody?
Well, exercise, we actually have it in the social history.
Okay.
You can fill it up in social history. So you talk about exercise. So that's in the previous one.
Yeah, so there is an activity here too as well.
That's fine. Okay.
So yeah, it'll be in here. There is an option to do an extra text box if you need to, but then there will be this one as well. So let me put a note down. And would that answer your questions, Yoman, as well? Okay. So would you need a physical activity box here, or that's not quite needed? Okay. And the dietitians on the line, are you guys okay just to put it in the social history rather than a separate physical activity box line?
Yep, that's fine.
Okay. Perfect. Thank you. All right, so I won't go too far into detail about all these specific areas, but feel free to do that outside of our meeting time and let me know if there's anything. There is one question I wanted to bring up is there is a monitoring and evaluation section in the dietitian forms, and let me know in an email or whatnot that you want an extra section regarding monitoring and evaluation and how that would look like. And we'll, again, combine it and see what we can put together. Okay, now, foot assessment. So foot assessment, Melody, correct me if I'm wrong, right now there's no specific area to document foot assessment this time, right?
Correct.
Okay, so you guys are just putting it in the auto text when you need to, right? Okay.
Yeah.
So what we're hoping is we would like to propose to have a foot assessment section in the power form, if possible, so that way we can document it. Now, there will be limitations potentially to this power form. So for example, if you guys are more used to using diagrams, that might be a bit tricky. And let's say if you guys do filament tests, that might be also tricky to put it in here specifically, but anything related to radio buttons, multiple choice boxes, and open text, we can probably put together something here, okay? So again, I will send this out to you guys. Feel free what sections you guys want. This is right now just a combination of what we saw in the VGH section and the SBH one. So Richmond folks, if you need, if you see anything that's missing or any site that's missing, just let us know and we will mock it up and share with you guys to kind of have a final confirmation. Okay.
Oh, sorry, I missed it. Are you not allowed to put an image, you're saying?
It might be tricky to add images inside in a PowerPoint. So if that's something you need, we'll have to, I'll have to get back to you guys about that.
Yeah, that would be something we'd want really, if you could, because honestly, that's part of the assessment. We have to document what points were basically done.
And that's mainly for the filament test,
altered.
Right?
Yeah, it's for the filament. And yeah, you kind of have our image that we have on the VGH assessment form. Yeah, that's what you'd want.
Okay, I'll bring it back and I'll let you know how we can, like, let's see what we can come up with. Okay.
Awesome.
And then all the other ones would be kind of like drop down boxes and all that. All right. Now, I know some sites do gestational DM stuff. Right now, we are trying to figure out what is available in Cerner to provide documentation. So again, if you can go through this and let us know if there's anything missing, and we'll try to match it up as much as possible. Okay. Just so you guys know, the Children's and Women's Gestational Diabetes Clinic is not planned to go live yet. So when that does happen, there might be a discussion from all the GDM sites on this, okay? So just keep that in mind, because I know Richmond has something, St. Paul has something, but VGH usually doesn't deal with it. So just keep that in mind.
Hey, Stephanie, it's Keisha here. Just to say, down in the monitoring, it says picky, but where you've got urine, it should be the ketones. You didn't spell it correct.
Oh, good catch.
Sorry.
No worries. Good catch. Good catch.
No, it's picky, but
yeah, Excel doesn't have autocorrect, unfortunately. So, okay, awesome. So yeah, let me know what you guys feel like, and then again, we will have to probably connect this with the CNW folks in the future. Okay. Yeah, so that's basically right now what we have in mind. I hope this is a good kind of quick tidbit of how this looks like, how it can help you guys, and a better image of how it can look like. Again, email us about all the comments. We'll combine them, put them together, and then we'll chat more on February 18th. Okay. Any questions so far about the PowerPoint? No? Okay, perfect. So right now we have about 40 minutes left. So what I'll do is I'll go through some things really quickly, and I'll defer some things for the next session when we need to. So in terms of other ambulatory clinic workflows, I do want to touch base really quickly on triaging referrals, because that's something that is a thing, a component of both Keisha and Melody's job, and also in the Richmond clinic as well. And I just wanted to quickly kind of get you guys to think about is we do have the referral management window that allows you to sort out. So what I'll do is I'll actually show you guys really quickly. So right now, what we can do is once the clerk kind of puts all the information in and sets it all up, what it does is within PowerChart, there is a referral management button up here. You can actually see all the referrals that come in, and you can triage it through there.
Are you showing the PowerPoint right now?
Oh, Carmen, is there a question?
Sorry, just wondering if you were showing the PowerPoint right now. We're still in Excel.
Oh, sorry. I will. Let me switch up. This might be better.
There it is.
Okay, awesome. So, Melody, are you guys using the referral management tab?
No, this looks very different from what we have. I could be like, it's a little bit different. We're going into our patient list. Like we pull it up from patient list.
Is it from PM Office? Were you guys looking through PM Office or
Ambulatory organizer?
Okay, okay.
So that's how we see it from.
So through this, basically.
Yeah, and through the patient list.
Okay.
So we go through patient list, and then it lists off all our we have like a tab that goes to referral.
Oh, okay, perfect.
So at the top button there, it says patient list.
Sorry.
On the top home, yeah, that toolbox, patient list. There you go. Yeah.
So this one.
Yeah.
Okay, yeah. So that is another way to go in here, and you can add your own. So there you go. There's an example here. Yeah. So referral, you can also put go through here as well. So there are options. They probably have some that have comments, and we're hoping that this would be a good capture of what referrals you guys have, your referral list, wait list, and all that stuff. We're hoping to kind of go through that. Now, I know you guys are still have, there is a tricky bit about finding information to kind of match up with your referral. For the external ones, it's a little bit easier because you have the referral form already. The internal ones is a little bit trickier, like we mentioned. Yeah, so for now, I'll just say there is available for you to triage, and then as a nurse, you can accept or reject a referral, or bring it back to the clerk and say, hey, can you add more information, or can you ask for more information on that side? Okay. All right.
We, funny enough, we don't use this referral management. Can someone teach us this? Because this is so much better than the patient list that we were taught.
You like this one more than the patient list?
Well, because the one thing I was going to complain about the patient list referral is that we don't know when the referrals have come in. And here I can see that your referral received date. Yeah. And, that was the one ticket that I put in, and no one told me that we have this referral management. So.
Oh, okay. Maybe I'll come by next week and we can go through it a little bit.
That would be great. Thank you.
Okay.
When we're triaging, we have a whole long list. You don't know which one came in first.
Yeah, we have no idea.
Get 20 referrals.
We're just picking and choosing basically of who to pick. And, we can have someone who's been on there from last week, but not realize that, we're picking someone who just got referred yesterday. So again, like I said, I asked CST about this, and they said that there's no way to do that, and they didn't tell me about the referral management. So we don't even know about this referral management.
Oh, okay, there we go. So I will come by and share it with you guys next week. Okay, we'll set up some time to do that. Okay, awesome. Good to know. But yes, there is a referral management page for you guys that require to do triaging. And we'll go through a little bit more in detail about this next time when we do more of a workflow demo, but I just wanted to bring that up to you guys. And in terms of just the diabetes nurse educator piece, we do have some questions for Keisha regarding this. So what I actually might do in the interest of time is to email those questions to you, and if you can answer them for us, that would be great. And so basically the questions we have is just, what are you guys consulted for? How often do you guys get education consults? And then how does it transfer over to your clinic, these consults, and would they end up being referrals to your clinic? And also just a billing and funding question. Now, in terms of the diabetes nurse educator workflow, we do want to clarify two pieces because we just wanted to make sure if there are differences to the St. Paul's workflow, or would it be kind of similar? So the first question, I guess, for St. Paul's is, do you guys get consult orders pulled in the inpatient, or is it more of still like a pager, phone, email kind of?
I don't know. That was the one thing we also had a question about. Sometimes we get a pager, and then the pager will tell us that something is on our, I guess, multi-patient task list. What it is. That's where it pops up. Sometimes we find that a patient pops up on multi-patient task list, but then it doesn't page us. Again, something I asked about, and they said that it depends on how the provider is putting it, whether it's an urgent or something. But from what I know from the providers, they're like, I don't see anything like that. So there's like a miscommunication there.
Okay, so I'll confirm that and kind of I'll go in and take a look that a little bit more. But most of the time, the docs know how to put a consult order in for you guys, more or less. You guys don't use like a external pager or phone or email.
Yeah, there is an external pager. There's a number that they can call, but we usually suggest that in order for us to know who we're going to visit, and we won't know. And part of our stats is to make sure we count who we're seeing. So we need to get them to place that order. So majority of them do know. There was an issue at first though, because there was different kind of options that they can have, which were diabetes education, diabetes nurse consult. And so they were putting in these things thinking that we were getting told, but nothing was coming to us. So we had to take out that order. So I don't know, knowing that we're going to be on with VGH, there should be a separation. I think like something has to, verify that you're paging the inpatient nurse from St. Paul's rather.
Yeah. So what happens in the future now that there's more than one site, is that the multi-patient task list can be filtered by St. Paul's and VGH. And then in the future, it'll be filtered for Richmond as well. So it will be a filter on the multi-patient task list rather than a order filter on the provider side.
Okay, so an order, so basically if a physician from St. Paul's requests for an inpatient diabetes nurse consult, it'll go to the SPH. It won't.
Exactly.
Okay.
So as long as you filter that if you're only seeing St. Paul's inpatients, then it will show as only show up the St. Paul's. And it'll be really obvious in the multi-patient task list. It would be like, oh, why is there a VGH, I don't know, T7 in there randomly. So you'll see where that patient is. And that would be filtered out. It should be filtering out.
Okay, I'm not concerned about the multi-patient task list. I'm concerned about the provider ordering it, right? Like,
so the provider won't need to specify anything. It'll be more just the filter of the multi-patient task list.
Okay, because like I said, the issue we had was there were two orders, one for Lionsgate and one for us, and they were getting our orders. So it was like, we had to distinguish that, right?
Yeah, so that was an issue that we ticketed and we reported, and that should be resolved as much as possible. However, if you do see that happening, just let us know. We'll open it up and take a look at that as well too. Just so everyone know, for those who don't know the Cerner jargon, this is going to be a new replacement for the pager. The pager or the email or the phone call that they would be able to provide, send an order, and that will pop up in your task list for the inpatient nurse on duty. Okay, so for VGH and Richmond, just so you guys have that in mind. Now, the second question I wanted to ask you guys is, in terms of education and all that stuff, I know I kind of got a good understanding of how St. Paul's is doing it, but in VGH, let's say if you're getting an inpatient consult and the patient needs a pump or a pen or any sort, how does that work typically?
Well, so first of all, like, just to clarify, we don't give someone a pump, and we don't supply supplies for their pump either. So they need to bring that in because it's self-managing. So if they don't have those supplies, and then obviously the physician would order them to have insulin via an injection, and they would get that medication via the pharmacy. And then the other thing is, what else did you ask? Sorry, Stephanie.
So any pump or pens, anything, would there be any instance where a patient would be inpatient and now says, oh, I need a pump now, or I need a pen, or that's very rare?
So again, they could ask, they might say, okay, well, they might have a pen where they have their insulin put in the pen, and we could provide that. But we're not, like I said before, we're not to give samples of insulin. We're not a dispensing pharmacy, so that's not our role.
Okay. Okay, so anything will have to be like a once they discharge kind of thing.
Yeah, like, I mean, they might say, oh, look, say they're on a glucose meter and they've run out of some strips. Ideally, we're not here to supply it. We might give them a sample of 10, but that's not our role as an inpatient. Then they can use the ward stock. Like they would basically use the ward glucometer if they were in for a period of time.
Okay, all right, so we'll make note of that so that when we're thinking about workflows, that would be good. And thank you, Suman, for clarifying the Richmond workflow as well. All right. Now, quick update on the diabetes workflow management. I know some of the St. Paul's folks are actually seeing that and finding that kind of useful on an inpatient setting. So I'll go through the workflow management a little bit more. It is built currently for the pediatric setting, but we are vouching to kind of make it more for the adult setting at this time. All right, so I'll just skip through these ones. And then, okay, so I wanted to chat with you guys about position picker. It's something that the St. Paul's Clinic nurses do have. So we want to make sure that when VGH does go live, we are aware of that as well. So position picker is something when you have one role and they're doing two different things at the same time. So for example, if a nurse is both in the ambulatory setting, but also have to go into the inpatient setting, then we will have to make sure there is a position picker available to that nurse so that when they go in inpatient, they have a totally different view. They see all the different things and they're able to document in a different way. And similarly, in just an ambulatory setting, so let's say if the social worker in your clinic does their own schedule, so they would need to also have the social worker position and also have the scheduling attached to it. There are some positions where that's already kind of built in. And we can, when closer to go live, there'll be someone kind of talking to you about these, but we just wanted to get an idea of, in addition to the two that I posted for, this would be specific to VGH. For the two that we have posted here, are there any other positions in your clinic that will require inpatient, outpatient, or scheduling and their own work? No? So those two are the two that probably will be, and for St. Paul's are the, like, right now position picker is just for nurses, right?
Yeah, so we have ambulatory nurse and patient educator, which is the
Patient
inpatient nurse.
educator, okay. Yeah, because that's, I think, what we're going to include as well. So it will be ambulatory nurse and patient educator, because what you view and see will be very different. Okay, perfect. I just wanted to double check that. All right, so we're on to basically our second last topic. This would be just an FYI. So we understand that if Cerner is down in any reason, planned or unplanned, there will be a need for a downtime procedure. And for any of the sites that have Cerner already, you guys probably are aware of what's going on or have someone trained to do that piece. Now, in terms of those who are not in Cerner at this time, typically there will be two main things that will be added or kind of put into play in your clinic. So the first thing is something called a 724 computer. Some of these computers are actually separate computers, or some of these computers will be your clerk's computer. And what that happens is basically these computers will never be turned off. It records something every 2 minutes. There will be some maintenance on the clinic's end to kind of maintain some of these things. And what happens is when there is any downtime on Cerner, this computer is kind of like your offline mode for everything. And that you'll be able to access everything and be able to do your work on a continued basis. In ambulatory clinics, you guys have a bit more flexibility about like, oh, we can just write it down on paper first and then we'll put it in later. It'll be a bit more specific on the inpatient side. So for those who have nurses with inpatient needs, you might see this a little bit more often. The second thing to keep in mind is there will be something called downtime gray boxes. And these gray boxes are basically your form repository, all your procedures, and that box will be created for you guys specifically for the clinic. And all this stuff will be done closer to go live. There will be someone from CST coming in and making sure that all this stuff will be ready for you guys. And there will also be, after go live, there will be a go-to person for anything related to downtime. And all the training, orientation, and preparation, you'll see that closer. But we just wanted to give you guys a heads up and give you guys an idea of like, okay, this is what to expect. Okay. All right, and then for the workflow summary, I'll bring it back to Carmen.
Thanks, Steph. Just gonna share here. All right, someone give me a, yes, we can see your screen if you can see my screen. Gonna go with silence is a good thing here. So I just wanted to show very high level end-to-end workflow, patient coming into the clinic, out of the clinic, and make sure that we're not missing any major gaps. At our next session, we're going to do an in-system demonstration of this workflow from end to end. Just see that we have something in the chat here, just going to make sure. So step one, we received that referral. We talked about that today, how that can happen from internal sources or external. The next step is the screening and triage completed at VGH by the PCC. It's then accepted or rejected. This appointment is scheduled through the clerk, whether that be online, virtual or in person. The confirmation of the appointment is then sent to the patient. And then we move on to day of appointment, where that patient is checked in and fully registered. And we have a few takeaway points here as to how that's going to happen virtually. We'll come back to you with some options on that. Next, the next three steps can happen sort of in tandem, as it sounds like there are some shared appointments as well as RN or RD or endo-only appointments. And then the medication administration is sounds like a fairly rare occurrence. And then lastly, that follow-up and patient departure piece. Are there any major gaps that we're missing in this workflow? Perfect. So that's all we had on the schedule today. We did skip over a few sections just in the interest of time. Any questions from anyone on the line that you'd like to bring up now? We do have a few minutes, so it would be a great time to sort of bring up any parking lot items that we had.
I did have a question because you did mention it. It was just to do with the inpatient referrals. So you mentioned that coming into Cerner, like then, and Melody had said as well. So right now, if someone from the wards are wanting to refer to the diabetes clinic, then it's done through, obviously through Cerner. So there's no paging system for the educator. Is that correct?
I'll answer to that. So I guess I missed the slide that I actually intended to share with you guys. Let me go back to it. So, okay, if you go to Carmen, are you able to go to slide 37 for me?
Sure, I'll make everyone not busy. Hold on.
Thank you. Okay, so I just wanted to touch base with this. So right, as of right now, there are two ways to refer to you guys. So the first way is through the diabetes nurse, and then the second way to actually to the clinic. Now, anything referring inpatient we'll call a consult. So there is a diabetes educator consult, which is separate from the diabetes clinic referral. Okay, and that would be two separate things. The diabetes educator consult would trigger and a kind of like a task or a to-do list for whoever is the inpatient nurse seeing the task list on their basically their front chart, front of their screen. The referral is anything related to outpatient. So let's say if the endo wants to refer someone into the clinic, it'll be a referral. And that would trigger to go to the clerk, get a new encounter going, and also get and punt it over to you to triage. So they actually now can separate these two, and they won't, and it'll be quite obvious because one would be actually called a consult and one would be a referral.
Yeah, I understand that. I mean, that's pretty simple. But what I meant was, I thought there was a conversation that you had mentioned about, was it the multitask or something? I don't know what it was called. That Melody had brought up that that if they're wanting to do it with the through St. Paul's or Lionsgate, you mentioned something. I don't know if that was to do with the diabetes educator consult. Like consultation, I'm not sure. So if you can just explain that, because obviously we are not doing this yet. So I just wanted to know what, just to clarify that point.
I can talk a little bit about it. I don't know if that might help her. So whenever, before Cerner, we would just get a pager, right? And then we would just look up the patient. Now we have this multi-patient task list in the position of patient educator. So we're not in the ambulatory clinic, we're in patient educator role. And so this multi-patient task list will, anyone who does a consult, so they want a nurse to come up to the into the hospital, their name will pop up on this multi-patient task list. So this is the list that she's showing now. And it'll tell us that this patient is on this ward. So you can see the location that they're on in the hospital and why are they consulting us. The issue we had prior to this was that because Lionsgate has this order, and what was happening was providers, so like the CTU team, our endocrinologists were putting in an order for diabetes education, thinking it was going to us, but it wasn't. We weren't getting it. So they call us like a day later and be like, "Oh, you haven't seen our patient yet," and we're like, we're not getting that order. So they've taken that out of our order list. So the provider now doesn't have that option. They just either have the option of diabetes consult, diabetic nurse consult.
Okay, that's great. Thank you.
No worries, no worries.
Yeah,
but yeah.
In the future, what will happen is when there are multiple sites, what that multi-patient task list will do is filter by hospital. So you will only, once the filters are set right, you'll only see the VGH ones, and the SPH will only see the SPH ones, and they won't overlap. You can obviously, if you don't specify, use all of it, and I don't think that's what you guys want. But in terms of the filter, you can filter them. And as long as the provider is putting in the right order, and right now, because there's only one option, they have no choice, it will trigger a to-do task list, basically, a patient task list specific to hospital.
It's so helpful to have your insight, Melody. Thank you for being here today. I think that we're seeing the beauty of multi-sites coming together and sharing their knowledge. So we appreciate that. I'm just gonna zoom us along here in our slides.
One more question. When we're talking about hemoglobin A1C, the A1C, we have a DCA machine in the clinic where nurses and dietitians can check A1C. With blood glucose, you can put it in as point of care. Is there going to be an opportunity to do that with A1C and a DCA?
Yeah, so that was actually one of the sections in the power form that we wanted to put in, because we did wanted to make sure that A1Cs are not just documented from labs, but there's another way of documenting that A1C if we don't see it. That's where that power form, that one most recent A1C, that could be your place to document that.
So even if it's done within the hospital with our own machine, it can still go in there?
Yes, and we'll also double check if we need to add a point of care A1C as well. We'll put that in our action list to see if we can put that into our power form.
Yeah, because a lot of patients don't go to the lab and they arrive here without it.
Right.
So, okay.
Okay, yeah, so for sure, I think we can look into seeing if we can add that as a section.
So in terms of next steps, we do have a couple upcoming sessions. So we have our scheduling requirements gathering on February 9th. And then our follow-up session 2 is on February 18th. So we'll be doing lots and lots of demonstrations in system at that point, showing you a lot of what we've talked about today. We'll go back and work on that and see what we can come up with. I'm going to say right now, I think we're going to need a third follow-up just because we have a lot to show, demonstrate, and ensure that we're capturing your needs. Just keep in mind that we will be going live with Children's and Women's end of February, so there will be a gap in time before that third follow-up session. But we'll be in contact with everyone. Just kind of wanted to give folks an idea of what's on the horizon in terms of your time and scheduling your work. But that is all for today. We really appreciate everyone's time. I know it's a long morning, but getting your insight and input is really valuable for making the system work for your patients' needs. We will stick around on the line here for a couple minutes. I'm just going to check the chat to make sure we've got everything. Perfect. Thank you. Yeah, so as I said, we'll stick around on the line if there's any remaining questions. I put my email and Stephanie's email in the chat. Don't hesitate to reach out to us. We are here to answer your questions and reach out to other people if we don't know the answer to those questions. Thanks, everyone.
Thank you. I put Suman in the waiting room.
Thanks.
I don't think she knows.
She asked, I think she can attend, what happens if she can't attend February 18th though?
Yeah,